Thank you. Could you please present the case to me?
So this patient has a lower motor neuron syndrome. Specifically, she has a symmetrical, non-length dependent, predominantly sensory motor neuropathy. On examination, she has evidence of reduced tone and she was areflexic. Power was reduced throughout the lower limbs, but particularly she only had anti-gravity movements in hip flexion. I noticed that she was hesitant when checking heel-shin coordination, and sensation was impaired to the mid-shin. On examination of her gait, she was unsteady when standing and walked with a broad-based ataxic gait. I did not perform Romberg's test, as she was clearly unsteady when standing still. I'd expect Romberg's to be positive, given the degree of sensory impairment. Putting these together, as I said, it's a lower motor neuron syndrome, and whilst the features are atypical, you need to consider the common causes of a peripheral neuropathy. These would include diabetes, alcohol excess, vitamin B12 deficiency, and hypothyroidism. However, given that these are quite atypical, and I noticed that she was wearing a steroid bracelet, we'd need to consider an immune-mediated neuropathy. If this was an acute onset, we'd need to consider Guillain-Barré syndrome. However, if this has come on over a more prolonged period of time, it could be due to CIDP. It could also be due to a systemic inflammatory condition, such as Sjogren's, SLE, or rheumatoid.
You've suggested a possible immune-mediated cause. What features in the history might help support that diagnostic contention?
So I'd be looking at the onset of the symptoms and how they've progressed. So if these symptoms have come on acutely, for example, they've noticed weakness in their lower limbs over a period of days, then I'd be considering a diagnosis of Guillain-Barré syndrome. If this had come on over a longer period of time, then something such as chronic inflammatory demyelinating polyneuropathy would need to be considered as well. In inflammatory or immune-mediated neuropathies, we expect to see a waxing and waning of the symptoms. So have they got better and worse over a period of time? Are they static? And if they've changed and got better and worse, then that's more likely to be immune-mediated as well. Also, where did the symptoms start? So, for example, if the symptoms started on the hands or on the face, that would be unusual unless it's immune-mediated. Similarly, if they have any truncal symptoms as well. In patients who are presenting with predominantly ataxic syndromes, they are again more likely to be immune-mediated in nature. It would be important to look for any signs or in the history which would be suggestive of systemic inflammatory conditions as well. So is there any features of an inflammatory arthropathy, which would mean that I'd be looking for early morning pain or stiffness in the joints, which gets better as the day goes on. Have they got any skin changes, for example, on photosensitive areas which are exposed to the sun, or any other unexplained rashes that they've been experiencing? There's the general Sicca syndrome as well, so have they got dry eyes and dry mouth, which would be more suggestive of things like Sjogren's syndrome. You'd also need to explore the patient's current and previous medications. Have they received any biologic or chemotherapy agents, which could explain these symptoms as well?
Okay. You wanted to complete the neurological examination, doing the cranial nerves and the upper limbs, which is a good idea. What features would you be particularly on the lookout for?
So I'd be looking again for an immune-mediated features. So checking the upper limbs to see if there's sensory impairment in a glove and stockings distribution. If this wasn't present, then it's likely to be non-length dependent, and this would lend itself to a diagnosis of an inflammatory neuropathy. And again, we don't generally see facial sensory loss in conditions which aren't inflammatory in nature.
Okay, thanks very much.